You've been looking at the use of a stander in patients with spinal muscular atrophy. Can you tell me what it was that you were trying to look at? Why was the reason you embarked upon this interesting study?
Of course. Well, we were able to use a large natural history database that followed children with spinal muscular atrophy over time to better understand who was using a standing device, who didn't use a standing device, and what the frequency of their standing was over a period of time.
And what did you do to embark upon this study?
Well, it's a retrospective study, so we mined data from historical data, and we also wanted to explore factors that were associated with standard use to see if there were any predictors to help physical therapists make clinical decisions about who might be appropriate for using a standing device, particularly among children with SMA who are non-ambulatory, so types 1 and 2.
Could you tell me a little bit more about spinal muscular atrophy and what you're doing in this specific study that's different?
So spinal muscular atrophy is an inherited progressive genetic disease. And in this case, we were interested in children who had type 1 and type 2 who were non-ambulatory and unable to walk, children who might be more likely to benefit from using a standing device. And so what was different about what we wanted to do is this was quite a large study. We had a database of over 400 patients, and over 300 of which we actually had data about who was standing and how often they were standing and over what periods of time.
And these were patients who had not received some of the newer drugs that are changing the course of SMA, weren't they? So they're actually a natural history cohort.
Absolutely. This is a natural history cohort, and all of these data that contributed to the study were collected before the disease-modifying drugs were available, either in clinical trials or FDA-approved drugs.
So what did you find?
So what we found is that both children with type 1 and type 2, there's feasibility. They're able to stand. Of course, the prevalence of standing was higher in children with SMA type 2, who traditionally in a natural history cohort are the children who are able to sit. But we also had a percentage of children who were type 1 that were never able to sit, who were also able to stand.
What was it specifically about the standing device that you needed to establish?
Well, I think what we really wanted to know is, are children with SMA types 1 and 2 able to stand? And if so, how frequently can they stand? And this wasn't an experimental study. This was when it's prescribed and recommended as part of an intensive multidisciplinary care plan. Are children with SMA who don't ambulate, are they standing? And so what we found was that both children with type 1 and type 2 can stand. The prevalence of stander use was much higher in those with SMA type 2 who are able to sit but not able to walk. But we did have a percentage, I think it was 13% of the children with SMA type 1 were able to use a standing device with a significant amount of bracing. And there were some interesting predictors for which children with type 1 were able to use standing devices. Supportive standing for non-ambulatory children with SMA is recommended as part of care guidelines. However, those recommendations are based on expert opinion, and we haven't had a lot of evidence in the past in which to guide clinical decision-making around standard prescription and standard use.
Right, now you've got a big cohort here, so what did you find?
So what we found is that children with type 2 SMA, the vast majority of them who were standing were able to stand using a standing device, and they achieved frequency that was akin to the care guideline recommendations, so between 3 and 7 times a week. So that was for children with SMA type 2. For children with SMA type 1, a smaller percentage were able to stand in a standing device and reported consistent standing over time. But some were able to. Some children with type 1 were also able to stand using a stander.
So what are your conclusions coming out of this?
Our conclusions as authors were we need to be, it upholds the care guidelines, which say that supported standing is a recommended element of comprehensive care for a child with SMA, and also provides a little bit of guidance about the feasibility of standing more than 3 times a week, which is certainly achievable for some children. There's some important things that you need to think about for children with SMA type 1, though. Now, most of them will have been treated with a life-altering drug. And so their prognosis for achieving sitting and standing is much, much better if they were treated very early. So, so it's important to keep in mind that this particular cohort was a non-treated cohort, but that use of a standing device should be considered for all children with SMA type 1 and 2.
What are the clinical implications in everyday practice of your findings, you think, for physical therapists around the planet?
Well, other than making sure it's important that you're thinking about prescribing and using a standing device and recommending that, one of the most important things I think that came from this study was an awareness that adverse events can happen with use of a standing device in children with SMA, particularly for those who have poor head control and are at risk for respiratory occlusion. So one of our most important roles as physical therapists is, maintaining the safety of our patients and educating families to make sure they understand how important 100% time direct supervision is when you have a child with SMA using a stander, because we have to prevent airway occlusion. We had very rare instance of adverse events, but because this was such a large sample, we did have 2 children who had either a respiratory or a cardiac event while in the stander. And in both of those instances, the family member was outside the room for a brief period of time. So that direct supervision is really critical, and it's our, responsibility and role as physical therapists monitoring their standing programs to make sure that families know that, akin to the American Academy of Pediatrics and how they recommend that a child never be left alone in the bathtub, it's the same for in a standing device. A child with SMA in a standing device can never be left alone. Direct supervision is always needed.
So if you were to summarize very briefly in 10 or 20 seconds what you found and what the take-home message is, how would you do that?
I would say standing is feasible for children with SMA type 2, and also in many cases in children with SMA type 1, particularly if they have some rotatory head control. And also particularly for children with SMA type 1, if they have ventilatory support.
And now that disease-modifying drugs are available, how much has the picture changed?
Well, the picture has changed quite a bit, but I think there's still a potential important role for the use of supported standing in children, particularly in children now with type 1 who are weaker, who may receive life-changing drug, but we may still need to enhance the chances that their outcome is going to be as good as possible. So if we want them to become walkers, it might take longer for them to be able to do that. And so supported standing may be an important bridge to these children learning how to stand independently and how to walk.